Data by itself is just numbers and text. Without organization and context, a patient's health record is essentially useless to a practitioner. It's the classic rule of computing: garbage in, garbage out. Consider a busy physician hurrying to type a standard order for penicillin. They intend to type 250 milligrams, but in the rush, their fingers slip, and they enter 520 milligrams into an open text box. That simple transposition transforms a routine order into a life-threatening dosage. To prevent these exact scenarios, modern electronic health records rely on two distinct but interlocking principles: data quality and data integrity. Quality is about usability. It measures how reliable and effective the data is for operations and decision-making. Integrity is about trustworthiness. It ensures the data has not been altered in an unauthorized manner during storage, processing, or transit. Securing a health record requires engineering both quality and integrity simultaneously. The system architecture must move beyond fixing errors after they happen and actively constrain how data is captured in the first place. It is entirely possible for a record to be perfectly secure and completely useless. A cryptographically locked file that correctly preserves a vague entry of "patient feels bad" has perfect integrity, but zero clinical quality. On the other hand, a physician's highly detailed, highly actionable progress note loses all its value if the database allows an unauthorized user to secretly alter a diagnosis after the fact. High quality means nothing without integrity. The volume of risk a healthcare organization assumes is dictated directly by how they architect their data capture, the actual physical process of recording information into the clinical database. Mitigating this risk falls to health information management and clinical documentation integrity professionals. They are tasked with ensuring the system collects the right data the right way. Without strict governance, the very tools designed to make data entry faster will automatically become high-risk vectors for replicating and spreading documentation errors. An unstructured, free text field allows a practitioner to type whatever they want. While this maximizes flexibility for the user, it complicates data retrieval. One doctor might type Lou Gehrig's disease, while another types amyotrophic lateral sclerosis, splitting identical conditions across different terms. This graphic displays several common types of structured data fields, including drop-down boxes, checkboxes, and radio buttons. These tools act as the mandatory first line of defense against clinical ambiguity. By limiting the user's options to a predefined list, the system guarantees that everyone enters data the exact same way. If a patient is from Georgia, they are logged consistently as Georgia, not GA by some and spelled out by others. This enforces data consistency. For longer narratives, systems often use speech recognition. A physician dictates their notes, and natural language processing technology translates that audio into text to populate the final document. This workflow carries distinct risks. In front-end speech recognition, the physician edits the text themselves. In back-end recognition, a dedicated editor reviews the audio against the text. Studies show that unedited speech recognition carries a 7.4% error rate, but routing it through a human editor drops that rate to 0.4%. Even typing carries hidden risks. To speed up data entry, users rely heavily on copy and paste functions. In fact, research indicates that up to 46% of the text in clinical notes is copied from previous entries. This massive volume of replicated text threatens true authorship validation. When a document contains paragraphs authored by 3 different clinicians across 3 different days, it becomes nearly impossible to verify who actually recorded a specific observation. Pulling a preoperative order or a medication list from a previous hospitalization into a current encounter destroys data currency. If the patient's condition has changed, pasting outdated data can lead to administering inappropriate treatments. These speed-driven shortcuts bypass the user's natural cognitive checks. To prevent this, the system itself must be built to force pauses and demand verification. This diagram illustrates the AHIMA Data Quality Management Model. It serves as the gold standard framework for ensuring data retains its clinical value. The model is built around 4 operational arrows that govern the data lifecycle: collection, application, warehousing, and analysis. Radiating from those core processes are specific characteristics required for clinical validity, including comprehensiveness, granularity, precision, and timeliness. Health information management professionals enforce this model through rigorous audits.
They conduct quantitative analysis to scan the record and mathematically determine if required reports, signatures, or data elements are missing.
They also facilitate qualitative analysis, often enlisting physician advisors for peer reviews to verify that every entry meets the standards for documenting the quality of care provided. To ground these characteristics in reality, consider data currency. A chest X-ray from 6 weeks ago is practically useless to a physician trying to evaluate and treat a patient's active pneumonia today. The data must be up to date. Data definition is equally essential to avoid administrative confusion. A term like admission time must mean the exact same thing to the emergency department physician and the billing department, whether it means arriving at the hospital doors or arriving in the hospital room. Data relevancy dictates that the system should only collect information expected to be needed. A hospital avoids data bloat by not recording a patient's shoe size or eye color unless it directly supports their medical treatment. The AIMA model ensures the information is clinically meaningful. But a theoretical framework cannot independently stop a tired user from typing an impossible value into a text box. Because human error is an inevitable fact of data entry, the system architecture must physically restrict illogical inputs. This is where data integrity tools take over. The system relies on a data dictionary to standardize the attributes of every collected element. Running silently behind the scenes, metadata tracks file creation, permissions, and an unalterable audit trail of exactly who authored an entry. This table categorizes the predictable errors that routinely plague health information systems. Notice the explicit distinction between a typographical error, like a transposed social security number, and an illogical error, such as a patient temperature entered as 236 degrees. To intercept these impossibilities, applications use edit checks. If a user tries to input a blood pressure of 543/87, the software detects that the value falls outside pre-programmed limits and immediately flags the entry before it can be saved. Similarly, if a user types a discharge date of 1/252/023, an edit check halts it. The system then employs a mask to force the data into a strict format, ensuring compliance without requiring the user to manually type slashes. When these preventative checks fail or are overwritten, organizations must rely on data cleansing, a retroactive sweep to identify missing data, flag extreme statistical outliers, and correct internal inconsistencies. This requires a strict 5-step protocol: profiling to find the issues, standardization of formatting, deduplication of records, verification of accuracy, and continuous automated monitoring. Simply eyeballing a record to see if it looks right is known as face validity. While helpful, it is not enough. True verification requires deep statistical analysis to catch those extreme outliers that would otherwise skew population health data. Proactive edit checks on the front end, combined with rigorous data cleansing on the back end, form the architectural fail-safes required to defeat the garbage in, garbage out principle. Even with strict controls, legitimate mistakes make it into the final record. When an error is discovered after a physician has signed off, the organization must follow rigid legal protocols to amend the data. Once signed, the system immediately locks the entry to prevent invisible alterations. An authorized user cannot simply delete the mistake. Instead, they must unlock the record and create a second version, or attach a clearly labeled addendum, leaving the original state completely intact. The original, flawed information must be preserved within the database. This guarantees transparency for clinical tracking and provides a reliable history if the patient's care is ever evaluated for medico-legal reasons. Version control ensures the audit trail remains unbroken. It provides the crucial separation between an intentional, fraudulent alteration and a necessary procedural correction. The life cycle of healthcare data is highly engineered. Inputs are strictly constrained at capture, measured against the AHEMA model, and locked for integrity. But despite the sophistication of modern EHR architecture, technology alone cannot guarantee absolute accuracy. The final decisive layer of data governance is organizational culture. The system is only as effective as the people trained to use it. Leadership must actively foster a culture of accountability. If practitioners are apathetic, they will inevitably find ways to bypass system constraints with workflow shortcuts and careless data entry. A clinical database is just a collection of numbers. It is only through the deliberate synthesis of rigid system architecture,
and vigilant organizational culture that raw patient inputs are transformed into reliable, life-saving clinical intelligence.